Chapter 9 is the armamentarium and syringe preparation. In this chapter, we'll be discussing the main components of anesthetic equipment and supplies, the criteria for acceptance of local anesthetic syringes, the different components of the syringes, along with the different types of the syringes and their advantages and disadvantages. We'll also be talking about how to care for reusable syringes so that they can be used over and over again and sterilized. Now, when handled correctly, all of the equipment that we're going to discuss will ensure that the dental hygienist can precisely administer the local anesthetic agent to the patient without the risk of intravascular injection or cross-contamination. And so the anesthetic armamentarium has three main components, which is going to be the aspirating syringe, a disposable hypodermic needle, and single-dose anesthetic cartridge. Supplemental armamentarium is going to be the topical antiseptic, which that one is optional. The topical antiseptic is often placed at the diaphragm of the anesthetic cartridge, and we'll go over that later on in this chapter. The next one is the topical anesthetic, applicator, sticks, gauze, hemostat or cotton pliers, and the needle capping aid. This next slide here is going to show a picture of all of those things, the antiseptic here, the topical anesthetic, gauze, cotton tip applicators, we have the cotton pliers here, hemostats, aspirating syringe, long and short needles, anesthetic cartridges, and the needle sheath prop. Now, in order for, I guess what we look for in syringes is that they're durable and able to withstand repeated sterilization for the reusable ones. We want the syringes to be capable of accepting a variety of cartridges and needles from various manufacturers. Of course, they would need to be inexpensive, self-controlled, lightweight, so being able to use them with one hand, provide for effective aspiration, and then constructed also for ease in observation. The most important improvement of the syringes has been the addition of the aspirating harpoon, and what that does is it engages into the rubber stopper of the anesthetic cartridge. We are going to look at pictures of this and go over all of it, so don't worry if that kind of just sounds like I'm rambling on right now. We're going to look at pictures here in just a minute. These are the different components of the anesthetic syringe. So you have your needle adapter, your syringe barrel, your piston, and your harpoon, finger grip, and thumb ring. And looking at this picture here, so here's your needle adapter. This is where the needle goes in. This is your syringe barrel. So this is where the cartridges will be placed. You have your harpoon here. This normally is slid in right in here. And so your harpoon will engage right in here. This little part means the harpoon. D right here, this is going to be your piston. This is guide gearing, of course a spring. This is your finger. This is your finger grip, and this is your thumb ring. Okay. Now, where the needle adapter is, that's going to be located at the top of the syringe and is attached to the barrel of the syringe. And then the threaded tip allows the attachment of the needle to the barrel of the syringe. So there's a threaded tip, and you can screw that on right there. Whenever you're removing the needle from the hub, the hub itself can easily unscrew and inadvertently be thrown away, so that's something to watch out for when unscrewing the needle. On the syringe barrel, there's two sides to it. There's going to be a small window and there's going to be a large window. The large window is going to be where the anesthetic cartridge is inserted, and that's also going to allow for direct vision of the cartridge. So this is a really important feature because this is what the large window needs to be facing the hygienist or the operator whenever they're doing the injection so that they can readily see if there's a positive aspiration. It is critical that this large window, once again, it's critical that this large window faces the hygienist at all times. Okay. All right, we went over all of these already. Now the advantage and purpose of the harpoon. So what happens is to provide negative pressure inside the anesthetic cartridge, meaning to pull back on the anesthetic cartridge, or to apply that negative pressure, the clinician has to pull back on that thumb ring. That's going to cause the retraction of the rubber stopper, and assuming the needle has adequate gauge, blood will enter the cartridge following negative pressure that's exerted on the thumb ring, and that will let the clinician know if there's blood that comes back into the cartridge. That means that there's a positive aspiration, which in return means that the tip of the needle is within a blood vessel. And so at that point, depending on the extent of the positive aspiration, the clinician would want to completely remove, change out the cartridge, and reinsert to where they can see again if they get a positive aspiration. A clinician does not want to inject into a blood vessel if they have a positive aspiration. They don't want to carry on with injecting because that's going to increase the risk of systemic toxicity. So these are just different styles of finger grips. In this top picture here, there's the winged finger grip, and then in B, there's the wingless finger grip. Now keep in mind this finger grip attaches to the barrel of the syringe, and that finger grip is going to be what allows the piston to pass through and attach to the thumb ring. It also gives the clinician added support of the syringe. Some of these finger grips here are even coated with silicone, and that helps to establish that firm grip. Now the thumb ring, there's a bunch of different sizes, or a few different sizes of the thumb rings. Up top you have the small or petite size, then you have medium, and then you have large. The contoured shape of the thumb rings, that's going to maximize control during aspiration. And so the whole purpose of the thumb ring is to add control over the syringe and to advance or retract the piston, which the piston attaches here to the thumb ring and goes through. Whenever someone is applying pressure to the thumb ring, that's going to advance the piston to embed the harpoon into the rubber stopper and push the anesthetic solution out of the cartridge through the needle. Whenever one is pulling back on the thumb ring, that's going to provide that negative pressure and retract that rubber stopper, which is going to in return produce an aspiration. The reason why there's different sizes, of course, is because it accommodates different hand sizes. This shows an example of the silicone-coated finger grips and thumb ring that's going to aid in the firm grip of the clinician and reduce slipping during the aspiration tests. These are going to be available in standard or petite syringes. There are 7 types of syringes used in anesthetic procedures. We're going to go through each of them right now, but here are the 7 listed. So the first one we're going to talk about is going to be the reusable breech-loading metallic cartridge type aspirating syringe. This syringe has a readily visible cartridge, and this is the most commonly used syringe. listed here are going to be the advantages. So as I was mentioning, a readily visible cartridge, ease of aspiration with one hand. It's autoclavable, so it can be sterilized between uses, rust resistant, and long lasting. Now, the reason why having a readily visible cartridge is an advantage is, again, to detect positive aspirations and to observe the rate of solution deposition through that window. This is a petite syringe. Now, the disadvantage of smaller syringe is the inability of the clinician to deposit the entire cartridge of the anesthetic. A small portion right here, the unusable local anesthetic solution, a small portion of that anesthetic remains in the cartridge and is unusable with these petite syringes. Now here are the disadvantages. So heavy weight of the syringe, the size may be too large for smaller hands, and the harpoon disengagement may occur during aspiration. Now, what can cause that harpoon to become disengaged is a dull harpoon, excessive pull on that thumb ring, improper engagement of the harpoon during the syringe setup. And if the harpoon does become disengaged, then the clinician has to remove the syringe, re-engage the harpoon, and repeat the procedure again. Okay, the next one we're talking about is the reusable breech-loading metallic cartridge type self-aspirating syringe. Again, the advantages, readily visible cartridge, ease of aspiration with small hands, disengagement of the harpoon from rubber stopper cannot occur with these. They are autoclavable, rust resistant, and long lasting. Now the disadvantages, again, heavy weight of the syringe, size may be too large for smaller hands, thumb must be moved from the thumb ring to the thumb disc, and there could be insecurity of clinician accustomed to harpoon type syringe. So somebody who is used to and familiar with the harpoon type syringe may have a harder time with this self-aspirating syringe. Looks like this. It doesn't have a thumb ring, and the reason this was designed was to aid the clinician in performing aspiration. It can achieve the negative pressure necessary for the aspiration without the harpoon, which is nice. And the way that negative pressure works, it's achieved by a metallic sleeve surrounding the needle and resting on the rubber diaphragm in the cartridge. This is what it looks like. Again, it doesn't have a harpoon attached to the piston. The metallic sleeve of the self-aspirating syringe is located at the base, and it comes into contact with the diaphragm of the cartridge, and it stretches it to produce that negative pressure of the cartridge during the aspiration test. Okay. So this is going to be, there are some of them that are available with the thumb ring, but this one is called a half moon type, and then there's the thumb ring. With aspiration using the thumb ring, you want to apply pressure on the thumb ring and then release the thumb ring. With aspiration with the thumb disc, you want to apply pressure on the thumb disc and then release the thumb disc, and it will create that negative pressure and aspirate on its own. The next one is a reusable breech-loading plastic cartridge type aspirating syringe. The advantages of this one is that it's readily visible. It has a readily visible cartridge. If this one is lighter weight, it is plastic. The appearance of it may be less threatening to patients, and it does have ease of aspiration with one hand. The other cool thing is that it is autoclavable and chemically sterilizable as well. It is rust resistant, long lasting with proper maintenance, and it is a lower cost with the plastic. Now the disadvantages, again, the size may be too large for smaller hands. The harpoon in this one can disengage, and there can be some discoloration that happens on the plastic from the autoclave. The next one is the pressure type syringes. So these are used for PDL injections or periodontal ligament injections. They are designed to administer a measured dose of 0.2 milliliters of anesthetic. The disadvantage of these syringes is the cost. They can be pretty pricey. However, the syringe can provide reliable anesthesia to one tooth in the mandible. And it helps out whenever the field blocks, the nerve blocks, are unsuccessful due to the density of the bone, or when an inferior alveolar or a Gaugate's mandibular nerve block is unnecessary. These can provide anesthesia to a more localized, like one tooth area, which is nice. We're going to talk about all of the injections coming up, so don't worry if you're lost with the ones that I mention. This is an example, or it shows a picture of the pressure type syringe. The next one is the jet injector syringe, which is mainly used for topical anesthesia of soft tissues before the needle insertion of or mucosal anesthesia of the palate. Now, this is going to actually deliver anesthetic without the use of a needle. And another thing is that topical anesthetics can accomplish the same result as the jet injector at a fraction of the cost. And so due to the high pressure associated with the anesthetic administration with the jet injector, the patient may be startled by the force whenever this anesthetic is delivered. The next one is the computer-controlled local anesthetic delivery device, which was first introduced in 1997. And this was designed to replace the standard breech-loading aspirating syringe and in hopes to deliver a virtually painless injection of local anesthetic. Now, it's no longer marketed by Milestone Scientific, but it is in use worldwide. This is what it looks like. It's going to be called the STA, or single tooth anesthesia system. It has a feather-light handpiece shown here, and that's going to help to provide that ergonomic control. Okay, with the computer-controlled local anesthetic delivery device, there's going to be precise control of the anesthetic flow and pressure. There's a setting on it that you can change for a slow flow rate. It does have an automatic aspiration. It's lightweight and it eliminates hand fatigue associated with injections. The rational needle insertion is going to minimize needle deflection, but the disadvantage of this one is going to be the cost. Okay. Now, with that flow rate, it can be set for 1 drop every other second or on cruise control, where the clinician can control it by foot control as well. The next one is disposable safety syringes. These were developed as an alternative to the standard breech-loading aspirating syringe. The examples include the Ultra Safety Plus XL, which is going to be right here. This shows the syringe ready for injection, and in C it shows that the aspirating syringe is sheathed to prevent the needle stick injury. Now, the disposable syringes, or safety syringes, these are designed to provide the clinician with extra protection from accidental exposure to contaminated needles. And the sheath that goes over, it locks over the needle when it is removed from the tissue. So, another thing to keep in mind is the entire syringe is going to be disposable. With the routine maintenance of reusable syringes, there needs to be thorough cleaning and sterilization. Periodically, they need to be dismantled and lubricated with a light oil. And it's also good to keep a lookout for the need to replace the piston and the harpoon as needed. If it's time to replace the harpoon if it readily disengages from the rubber stopper or if the harpoon is bent. We're moving into the second part of this chapter. This talks about the objectives. We're just going to kind of glide through these for right now. Now for needle components, there's going to be the bevel, the shaft, the hub, cartridge penetrating end, needle shields, gauge, and length. This picture is going to show all of that. So the very tip right there, that's called the bevel. And with the types of bevels, there's a bunch of different types: short bevels, medium, long, multi-bevel, scalpel bevel. Basically what the bevel is it's the needle, it's the point or the tip of the needle. Patient discomfort, the reason why it's important is because patient discomfort can be minimized by the sharpness of the bevel. And we talked about the different configurations. It's important to know or to remember that the bevel needs to be turned toward the bone for patient comfort. And what can happen whenever you insert the needle into the tissue is something called needle deflection, which is where there's going to be some angle to the bevel. And the greater the angle of the bevel, the higher the degree of needle deflection as it advances through the soft tissue. Now, again, remember the bevel of the needle should be turned toward the bone. That's going to increase patient comfort during the injections, especially the injections that are administered in close proximity to the periosteum. So B, the next part of this is going to be called the needle shaft. The shaft of the needle is the length of the needle, and it's composed of a long tubular metal that extends from the tip of the needle to the hub. Okay. From the tip of the needle through the hub to the piece that penetrates over here, the piece that penetrates the diaphragm of the cartridge. Now, breakage of the needle is rare, but it can happen, and it especially can occur when the entire shaft of the needle is inserted to the hub. So you never want to insert all the way to the hub. The metal hubs are pre-threaded. They have a pre-threaded anterior that allows for easy attachment to the syringe, but the plastic hubs are not pre-threaded, and so those ones can be pushed and screwed simultaneously. There's different needle hub variations. The hub and syringe adapter are made either out of plastic or metal, and that's going to provide a means to attach the needle to the syringe at the hub. There's also different color coding for the needle length and gauge, and we're going to talk about needle shields to protect the needle that is inserted into the tissue, as well as the cartridge penetrating the end of the needle. So that's what the needles are kind of enclosed in, is going to be some needle shields that protects that needle and then also protects the portion of the needle that gets inserted into the cartridge end. The manufacturers of the needles determine their own color codes. Here, and I think that it is the same at the school, so 25 gauge is red, 27 gauge is yellow, 27 gauge short, 30 gauge short, and then there's going to be the 30 gauge extra short. Now, whenever I say gauge, it's going to be the size of the lumen of the needle. The smaller the gauge number, the larger the diameter of the needle. So there's going to be 20, 25, 27, and 30. Be careful because larger gauge means the larger diameter of the needle. It's not referring to a higher gauge number. And so also remember that the gauge selection is going to be determined by the depth of penetration and the risk of intravascular injections. Out of the three choices, 25, 27, and 30, the one with the largest diameter is going to be the 25 gauge, and the one with the smallest diameter is going to be the 30 gauge. The advantages of using a larger gauge needle, which is 25 gauge versus the 30 gauge, is that 25 gauge is going to have a larger lumen and going to provide better visibility. There's more rigidity, less deflection. There's going to be a greater accuracy in the target location because it's thicker and has less deflection. It's going to increase the success of the injection, and the needle breakage is going to be a lot more rare. Okay. Now, while it's still possible to aspirate with the smaller needles, the smaller lumen does not significantly impede the blood flow into the cartridge, and so it requires more pressure by the clinician. There could also be difficulty with the smaller ones in obtaining a reliable aspiration, and so there's more chance as well to there's more chance to disengage the harpoon. Now, we're going to talk about different injections, but it's recommended that the clinician use the 25 gauge needle for the IA or inferior alveolar block, PSA, and mental nerve blocks. Here's a chart to kind of show you. These are the common needle gauges used for intraoral injections. You have the 25, 27, and 30. And again, the gauge indicators are placed by the manufacturer to easily identify the gauge of the needle. And so they're color-coded often. So the length of the needle. For a long needle, it's going to be approximately 32 millimeters, and for a short needle, it's going to be approximately 25 millimeters. The extra short ones are approximately 12 millimeters. Now, selection of the length of the needle is based on the amount of tissue that needs to be penetrated to reach the target location successfully and then to deposit the anesthetic successfully. You never want to insert a needle to the hub. Now, inserting the needle all the way down to the tissue to the hub can cause you're at greater risk for breaking the needle in the mouth. The long needles are going to be used when there's significant needle penetration of thick tissue that is needed, such as for the inferior alveolar nerve block or the IA. Short needles are preferred for injections that require a lot less tissue penetration. The needles that are extra short are only going to be available in 30 gauge. Now here's a little visual of the length of the needles and how long they are as in terms of millimeters. And then you can also see over here the color-coded needles. All right. So needles are pre-sterilized and disposable. You want to change the needle after 3 or 4 injections on the same patient. And then you also want to cover the needle immediately after the administration of the injection so that the clinician and those around are a lot less at risk for getting a needle stick injury. Now, the reason why we say 3 to 4 injections is because needles become dull after 3 to 4 injections, and those dull needles can cause tissue trauma and pain on insertion or after the anesthetic wears off. It's super, super, super important to cover the needle immediately after the injection using the one-handed scoop method, and we'll go over that as well. So these are different recapping devices. The needle recapping devices are going to be found in all kinds of different forms, and the dental hygienist can safely cap the contaminated needle using the one-handed technique, thanks to these guys. This is the scoop method, so it's the one-handed scoop technique where you secure the needle utilizing one hand only. We have to remember to cover that needle immediately after the administration of the injection, and we have to know where that needle tip is at all times, whether it's inside the mouth or outside of the mouth, and knowing where the needle tip is at all times is going to help prevent injury to both the patient and the clinician. And then also it can help prevent accidental needle contamination if the tip touches any other extraoral surface. Once we're done with the injections, we need to always dispose of the needle properly in a sharps container. These are the different needle problems. So pain on insertion, pain on withdrawal. The reason why there's pain on insertion sometimes is because of dull needles. You can prevent that from occurring by changing the needle after 3 to 4 insertions. The pain on withdrawal is caused by a barb on the needle tip, which can occur during manufacturing, or if the needle contacts bone forcefully. How you prevent that is just never force the needle against any hard surface during the injection. If the needle even snags a sterile gauze, you want to change the needle. And the next part of it, so needle stick exposure to the clinician, that can be a needle problem, but to prevent the needle stick exposure to the clinician, as I was mentioning before, you just always want to make sure you recap the needle immediately after utilizing the correct method. You want to be attentive at all time, know where the tip of the needle is, request that the patient remain completely still before, during, and after the injection. Needle breakage can occur, although it is rare. Bending the needle, you never want to bend the needle. Sudden direction changes can occur. So if you have to reposition during an injection, you want to withdraw the needle almost completely and then change direction upon reinsertion. If you force the needle against resistance, that's going to be bad because needles are not designed to penetrate bone. And so another thing is, and that can break the needle potentially. Inserting the needle to the hub can also break the needle, because the hub is the weakest portion of the needle, and the likelihood of breakage increases if it's inserted all the way into the tissue to the hub. Also, if this happens and the needle does break, it can be almost impossible to retrieve the broken needle back. Okay, with the anesthetic cartridges, so they are glass cartridges, and they're going to contain the sterile local anesthetic drug and other contents for the single-use dose. Each cartridge is going to consist of the glass cylinder, the cartridge labeling, silicone rubber stopper, diaphragm, and aluminum top. Remember that they all are pre-filled with up to 1.8 milliliters of sterile anesthetic solution. here is the anesthetic cartridge. So right here, you're going to see that glass cylinder containing the anesthetic solution. On this side right here, this is the diaphragm, and then you have the aluminum cap here. And right here on D, which is inserted on this side, that's the silicone rubber stopper. That's going to be slightly indented from the glass rim. Okay. Now, the reason why, and we talked about this in previous chapters, but the reason why the cartridge contains 1.8 milliliters and not 2 milliliters of solution is because of that rubber stopper. Okay. The diaphragm right here, this guy, located at the top of the cartridge where the needle is inserted, this is where contamination of the anesthetic solution can happen if proper storage of these cartridges is not followed. Now the aluminum cap is going to fit neatly and nicely snug around the rubber diaphragm to help keep it in place. Okay. So the ADA color-coded bands on anesthetic cartridges to help identify drugs quickly and to help with confusion of drugs or help to not get mixed up. They're located on the body of the glass cylinder, and it lists the cartridge is also going to list the contents of the cartridge, the trade and generic names, drug concentrations, vasoconstrictor dilutions, expiration date, and the manufacturer's name. There's so much information on those glass cylinders, and we need to make sure we're looking at that every time, especially checking for things like expiration date. And I'll tell you in just a second what else you want to look out for. This is the volume indication label. Some manufacturers include this, the volume indicators on the label, and what these are for is they assist the clinician in determining the amount of solution that is deposited. Okay. This is the color coding for anesthetic cartridges, and it just goes down the list. So lidocaine 2%, just 2% is light blue, lidocaine 2%, 1 to 100,000, epinephrine is red. This is a common one that we use. However, you want to try to get familiar with all of the different color-coded bands so that you can easily identify which anesthetic is available for use. Okay, so again, this is what I was mentioning before. This is the rubber stopper being pushed in. The rubber stopper is approximately 0.2 milliliters, and so the total cartridge, instead of being 2 milliliters, it's going to be 1.8 milliliters. So care and handling of the cartridge, you want to make sure that you store the cartridges in the original container at room temperature in a dark place. There's such things called cartridge warmers, and they're definitely not necessary. The cartridge does not need to be prepared in any way, but you do want to look at the cartridge and look for the expiration date. You want to always discard it if it is past date, and you don't want to just throw these cartridges in the trash. They actually go in a pharmaceutical bucket that we have in the sterilization room. Now, if it was placed in a cartridge warmer and the anesthetic cartridge is overheated, it can actually cause a burning sensation during the injection, and that's going to destroy the heat sensitive vasoconstrictor drug and then also decrease the duration of action. So once again, they do not need to be warmed up before. The cartridges do come pre-sterilized, but some clinicians decide to wipe them down with the approved ADA disinfectant. You never want to place alcohol or sterilizing solutions onto that diaphragm, though, or onto the cartridges. So the different cartridge problems you can run into, there's going to be small bubbles, which the small bubbles can be 1 to 2 millimeters in diameter, and that's gonna tell you that there's nitrogen gas in it, which is harmless. The other cartridge problem that can happen is you can see large bubbles in there, which is going to be greater than 2 millimeters, and that can be a warning that the cartridge has been frozen. Another one is an extruded stopper. An extruded stopper plus a bubble is definitely a frozen cartridge. An extruded stopper without a bubble, it means that the cartridge was placed in a disinfecting solution. If there's a sticky stopper, it means that the cartridges need to be stored at room temperature. Now, burning on injection is another thing that can happen, which can happen due to the pH of the drug. The vasoconstrictor lowers the pH. It can be due to overheated cartridges. Expired solutions can also decrease the pH, and the preservative sodium bisulfite is oxidized to sodium bisulfate. That can cause burning on injection. Also, the cartridge may be contaminated with disinfecting solutions that can cause burning on injections. Sometimes another thing that can happen with the cartridges is a corroded cap, where white debris will be around the cap. That means that the cartridge has been immersed in cold sterilization. There can be rust on the cap, which means that another cartridge has broken next to that and is leaking on other cartridges. There can be leakage of the cartridges during injections due to the off-center perforation of the needle penetrating the end into the rubber diaphragm. And then another thing that can happen with the cartridges is, of course, a broken cartridge, which is going to be damaged during shipping and handling. Excessive force by the clinician. It can be a bent harpoon or needle not properly perforating the diaphragm. I would memorize all of the problems that can happen with the cartridges. These are questions that you might see again. Just know the things that can happen and what they would be from, like what would cause these problems. The supplementary armamentarium, so the topical antiseptic, as I mentioned before, is optional. However, if it is used, the patient has to be screened first for a possible allergy to iodine, and it should be used on patients who are immunocompromised. The topical anesthetic is going to be the most effective. It's going to be most effective when applied to dry mucous membranes for 1 to 2 minutes, and that's what can help with alleviating the pain prior to the injection. Now, the applicator sticks are going to be used, they're the cotton applicators, which is going to be used for the application of the topical. They can also be used to apply pressure during palatal injections, which is necessary so that it eases some of the pain from the palatal injections. The gauze is used to dry the membranes. It's also used for retraction so that your fingers don't slip when holding the cheeks. Gauze can be used for increased visibility and also stabilization. The hemostat or cotton pliers would be for needle retrieval. All right, so step 1. We're talking about preparation of the breech loading aspirating syringe. Step 1 would be select appropriate anesthetics and assemble equipment. Okay, basically setting up. You don't want to forget your PPE either. Step 2 would be to carefully evaluate the local anesthetic cartridge. You want to do this every single time before you're going to give an injection. You always want to evaluate the cartridge. Step 3 would be to wipe the rubber diaphragm with the disinfectant. Again, that step is optional. Step 4, you want to retract the piston of the syringe and insert the cartridge with the rubber stopper going into the syringe first. and then you want to engage the harpoon into the plunger. After you engage the harpoon, you have to make sure that you engage the harpoon first, otherwise you're going to end up with anesthetic solution everywhere. So engage the harpoon and then attach the needle. Again, if you attach the needle and then try to engage the harpoon, you're just going to end up spilling anesthetic everywhere. Step 8 is going to be to uncap the needle and expel a few drops. And once you're done with your injection, then you want to use the scoop method to scoop the protective shield back onto the needle. So unloading the breech loading aspirating syringe, again, you want to remove the needle and discard the needle in the sharps container. You don't want to recap the cartridge that's penetrating, the cartridge penetrating end of the needle. You also want to avoid inadvertently discarding the needle adapter. If the needle adapter remain attached to the needle, you want to remove it with the cotton pliers, which is why it's good to have those. You want to dispose of the cartridge in a sealed container, and again, at the school we have that white bucket, which is for pharmaceuticals, and that's where cartridges will be placed. This next part is going to be assembly of the single tooth, STA, single tooth anesthesia computer controlled local anesthetic delivery system. You need to have proper setup of the system so that it's effective for using the device. Step 1 would be connect the foot pedal to the front of the unit. Step 2, connect the power cord to the back of the unit. Step 3, activate training mode feature. Step 4, open the sterile handpiece package. Step 5 is optional, but you can break off the handpiece at any one of the preformed indentions. I've never used a single tooth anesthesia computer controlled local anesthetic delivery system, but I do remember learning about them, and I think they're pretty interesting, but I've never seen one and I've never used one. Step 6 in this would be to attach the wand handpiece to the system, connect the cartridge at the top of the system, and then rest the handpiece in the holder, and then it's ready for you to use. To disassemble that, proper care, of course, proper care to disassemble the unit, remove the used cartridge and then remove the cartridge holder from the top of the unit. To remove the cartridge holder, you have to use the 2 small access windows at the top of the holder. There are, especially for the breech loading, there are pictures in your book that I would make sure you look at, because it's kind of hard to follow along whenever I'm just telling you steps of something. It's a lot easier if you have a visual of pictures, and I'll try to find some videos to upload as well. So the review, it's critical every time to use an aspirating syringe. Aspiration, you want to aspirate every time. Once you're at your depth and angle of the injection, you want to aspirate to see if you're in a blood vessel. If you are in a blood vessel, that means you have a positive aspiration where blood comes into the cartridge. You can see blood in the cartridge. If you do get a positive aspiration with blood in the cartridge, then you will need to withdraw your needle and reposition, probably change out your cartridge and then reposition to where you're not in a blood vessel anymore. You'll have to re-aspirate. You want to use the correct size of syringe. That's going to be for your hands. Correct size of syringe facilitates aspiration and stability of the syringe. If the harpoon disengages during the injection, you have to remove the needle from the tissue and then re-engage the harpoon, redo the whole procedure. You always want to direct the bevel of the needle toward the bone, and we'll show you a little trick to help with that. The smaller the gauge number, the larger the diameter of the needle. You want to use 25 gauge needles for areas of high risk for positive aspirations, and then you want to use long needles when penetrating thick tissue. You have to know that it's so important to know the location of an uncovered needle at all times. That's going to help prevent a risk of contamination of the needle and needle stick injuries as well. Every single time, even if your patient falls into a medical emergency, the very first thing you should do before you even respond to that medical emergency is cap the needle. Immediately cap the needle after the injection, no matter what. You want to cap the needle by utilizing the scoop method technique to cap the needle. You never want to bend the needle, never insert the needle to the hub, otherwise you're more at risk for breaking the needle. You don't want to make any sudden direction changes while the needle is embedded in the tissue. Again, you're going to be at risk for breaking the needle if you do that. And then you don't want to ever use damaged cartridges. Now that concludes chapter 9. Again, if you guys have any questions, please feel free to let me or Dr. Gonzalez know. Thank you.